Okay, welcome back, everyone. Right now we get to hear a wonderful lecture from Brett Parkinson, and this is on an update in mammography, which is exciting topic for all of us, but we'll hear it from him.
First of all, I want to thank you for your indulgence. On my personal calendar, this was on for 4:30, May the 16th. So you can imagine how surprised I was at 10 till 4 when I was at Intermountain Medical Center firing off an email to a surgical colleague when I got a frantic call from our business office telling me, "You have the wrong date. You're supposed to be there now." And calculating where I was at the time, which was Intermountain Medical Center in Murray, and where this talk was going to be, I immediately panicked and I thought, well, my talk has already been sent. And she said, "No, your talk hasn't been sent." So within about a 30-second period, I was able to find my talk on my computer, send it over to our assistant, and then your fantastic staff was able to get that talk to you, and here it is. But I have to tell you, that wasn't the most stressful part of the situation. The most stressful part is when I was passing I-84 and I looked at my gas tank, and not only did I just have one bar, the light was flashing. So I thought, well, if I'm meant to give this talk, I'm going to arrive. If not, I will walk and I will be 45 minutes late instead of just 10 minutes late. Anyway, I certainly want to thank Teresa because I have never had such great service. When I pulled up in front of the Browning Center, there was valet parking, which I have not experienced as a speaker. I just had to warn the good assistant that I was almost out of gas, so please park close. Anyway, it's a pleasure to be here. I have been involved in breast imaging since 1991 when I finished my fellowship at the UCLA Medical Center. Things have really changed since then. And I suspect that some of you may have been practicing even longer than I have been practicing. And back in the day when we started, breast imaging was in its infancy. And things have really changed, and they have changed for the better. But one of the reasons it's changed is because of good surgical colleagues like you who have been so willing to work with us in radiology as we do what's best for women. I am proud to say that over the last 28 years, the reduction in breast cancer mortality has been significant. In some studies, up to 40%. And today, we are going to talk about some of the recent studies and some of the recent controversies in breast imaging and in screening guidelines. In 2018, about 41,000 women are expected to die from breast cancer, and 12.4% of women will ultimately develop breast cancer in 2018. But I think the statistic that is most startling is that 1 in 8 women will develop breast cancer. And I think for those of us who've had family members, we know that this is true. My mother was diagnosed with breast cancer back in 1974, about 2 weeks after Betty Ford was diagnosed. And then I think for those of you that remember, Happy Rockefeller, the wife of the then Vice President Nelson Rockefeller, was diagnosed with breast cancer. And there was very little mammography done in those days. So most of those women had their cancers detected on clinical breast examination. We have 3 million women who, in the United States right now, who have breast cancer, who have a personal history of breast cancer. One of the things that's important to remember is that most of the women who develop breast cancer do not have a family history of breast cancer with a first-degree relative affected. And one of the first things I hear from a patient after I have given her the diagnosis of breast cancer is, "But how can I have breast cancer? There's no family history." So I think one of the myths that we really want to debunk is that the women who are at risk are those with a family history. That is simply not true. For those of you who have been involved in the diagnosis of breast cancer, you know that most of the diagnoses occur in women with no prior history. And then another thing that we didn't know back in 1991 is about 5 to 10% of women carry the breast cancer gene, BRCA1 or BRCA2. And for those of you who have been keeping up, there is a new gene. There's the PALB gene, and there are also other genes that confer a risk of breast cancer, and we're looking for those now. And for those women, we recommend enhanced screening, and I'll talk about that. So what is the efficacy of screening? Well, we know that screening mammography reduces breast cancer mortality across multiple study designs and up to 50% in recent observational studies from Europe. Now, the effect varies by type of the study that is done and by whether women are actually screened or simply invited to screen. And that is an important distinction. And I want to make that distinction now because when you look at the old randomized controlled clinical trials from the 1970s and the 1980s, they are based upon the women who actually got screened. When they did these large trials in Europe and in the United States and Canada, what they would do is they would invite cohorts of women, some to be screened and some not to be screened. Now, say if you have 1,000 women that are invited to screen and you've got 1,000 women who were not going to be screened but we're going to have just clinical breast examination, the women who were invited to screen didn't have to be screened. A lot of those women opted not to be screened, but when they developed breast cancer, they were still included in the cancer registry, so their early death was counted against the screening group. So what we have is when you actually look at the randomized controlled trials, we are looking at the women who were invited to screen, not actually screened. So when the task force came out in 2009 with its revised recommendations, they looked at the randomized controlled trials only, and those are the women who were invited to screen, not actually screened. So keep that as in your mind as we go along. So the task force based its recent and then its updated guideline that screening mammography is recommended for women between the ages of 50 and 74 and every other year, and then not necessarily recommended in women over 75 or women under the age of 50. And of course, as you know, this caused quite a bit of controversy. But the American Cancer Society did a very thorough study, and this was published in JAMA in October of 2015, and let me refer you to that article. It is an exhaustive article, and what they did is they looked at all the randomized controlled clinical trials, but they also analyzed newer observational studies, and they included data from modeling and situational studies. And although randomized controlled trials are the foundation in supporting evidence for mammography screening, the American Cancer Society Guideline Development Group also concluded that contemporary, large, well-organized observational studies provided valuable information on the effectiveness associated with modern mammography. And when I say modern mammography, I mean digital mammography, and now we have 3D mammography, and those old studies didn't even look at that. And those of you who've been involved in breast screening know the difference between an analog mammogram, a digital mammogram, and now we have enhanced mammography with 3D. So this is what the American Cancer Society confusedly said back in October of 2015. Women age 45 to 54 should be screened annually, and they call that a qualified recommendation. And you're going to say, well, what's a qualified recommendation? Well, if you don't fall asleep, you'll find out what a qualified recommendation is because we'll talk about it. And then they said women 55 and older should transition to biennial or every other year screening or have the opportunity to continue screening annually. Well, if you're a primary care provider, what do you do with that? You have a woman, she comes in the office, she's 56 years old, and he said, well, you can go to every other year screening, or I invite you to screen every year. That's not a guideline. We're physicians. We are supposed to provide evidence-based recommendations for our patients. And then it says that women should have the opportunity to begin annual screening between the ages of 40 and 44 years old. Now, that's a qualified recommendation. So we've got another qualified recommendation. So what are they doing here? Well, they said in the article, if you dig down into the weeds, that younger women have dense breast tissue, and breast cancers tend to be a little bit more lethal in that population. So if you're going to screen, you better do it every year between 40 and 55. So what we have going on here is kind of a hodgepodge of information that was somewhat reassuring to us as radiologists because we've been recommending screening mammography for women ages 40 to 50 every year, but then again, it was confusing. So they also said women should continue mammography as long as their overall health is good and they have an expectancy of 10 years or longer. Qualified recommendation. And then it said something that I think shocked a lot of people, including patients and clinicians, and I'm going to weigh in personally on this as well. the ACS does not recommend clinical breast examination for breast cancer screening among average age women at any, or average risk women at any age. So what does this mean about self-breast examination or clinical breast examination? Well, I can tell you that about 40% of the breast cancers that we find at the Janice Beasley Harpixson Breast Care Center in Salt Lake City are because of women doing their own breast examination or clinicians finding lumps. Now, we're finding more and more cancers on screening, but I personally find it to be a valuable tool in our armamentarium against breast cancer. So the American Cancer Society organized an interdisciplinary guideline development group consisting of 4 clinicians, 2 biostatisticians, 2 epidemiologists, an economist, 2 patient representatives, and they consulted outside cancer experts. And they also selected the Duke University Evidence Synthesis Group to help with their analysis. Now, this is important because when the United States Preventative Services Task Force came out with its 2009 recommendations recommending against screening in women under the age of 50, no breast cancer experts were included. There were no oncologists, no radiation therapists, no surgeons, no radiologists. And they were very opaque about the kind of evidence they used in arriving at their conclusion. One of the strengths, I think, of what the American Cancer Society did in its study was they commissioned the Breast Cancer Surveillance Consortium to update previous published analyses related to screening and outcomes. And the ACS Surveillance and Health Services Research Program provided supplementary data from the SEER program. So after reviewing the science, the randomized controlled trials, and the observational studies, the guideline development group chose to assess its final recommendation as strong or qualified, balancing desirable and undesirable outcomes and taking into account women's values and their preferences. Once again, that doesn't sound like hard science, women's values and women's preferences. And the reason that that is such is because they started taking things into account like anxiety as part of a reason a woman may not want to get a mammogram. We'll address that in just a few minutes. So a strong recommendation from the ACS conveys the consensus that the benefits of the intervention, in this case the intervention is screening mammography, outweigh the undesirable effects. Whereas a qualified recommendation, and remember that the qualified recommendation was that women start at 40 and 45, and then again from 45 to 54, there is clear evidence of benefit, but less certainty about either the balance of benefits and harms or about patients' values and preferences, which could lead to different decisions. And the ACS noted in a footnote that the majority of individuals would choose the suggestive course of action, but many would not. So basically what they're saying is that the scientific evidence says that it's something we should do if it's a qualified recommendation, but when you balance it with things like the harms of screening mammography or the woman's values, that may change. So let's look at some mortality reduction statistics, which were published in the JAMA article. If you look at the randomized controlled trials, and you look at the patients who were invited to screen, the mortality reduction was 20%. Now remember, they never looked at the women who were actually screened. But if we look at more recent case-controlled studies, we see that those who were actually screened enjoy a mortality benefit of 50%, which was significantly more than when you look at those same studies and you see that those who were actually screened have a mortality benefit of 25% reduction. When we look at cohort studies, there's a 38% reduction in patients who are actually screened versus 25% who are invited to screen. So this whole concept of whether you are invited to screen or actually screened for a study is very important, and it's something that the popular press has overlooked in all of its articles about screening mammography. And I love the New York Times. I read the New York Times on a daily basis. I try to get the Sunday edition, but the New York Times has consistently not reported this fact, as many other major publications have not, this difference between being screened or invited to screen which I think is very significant. If you look at the American College of Radiology's guidelines, and our guidelines are that women should begin annual screening mammography at the age of 40, and they should undergo screening every year for as long as they are healthy. And if women actually followed those recommendations from the ages of 40 to 84, there'd be an almost 40% reduction in mortality. If you look at the ACS guidelines and you follow those guidelines, where women are screened from 45 to 84, there's a 33% reduction. But if you go by the task force, in women 50 to 74, there's only a 23.2% reduction, and that's what was reported in their article. They also looked at another important number that you may have overlooked if you weren't reading their report in its entirety. They said in order to save one life, you'd have to screen 1,904 women in the age group of 40 to 50. But what that number did not include was the women who were actually screened. And if you look at the women actually screened, the number is much less, on the order of about 700 to 800. So once again, when you don't include that important detail, the data can be misleading. Let's talk about some of the harms of screening mammography. I believe in full disclosure here. What we do doesn't, what we do may have some downsides, so I'll just be upfront about that. Mammography is not a perfect screening test. We actually have, about 80 to 90% of cancers will be detected mammographically, but there are still those cancers which elude our detection on screening mammography. And that can happen in the younger age group, women with very dense breast tissue, and it can also happen in younger women. But some of the other harms of screening mammography are what they call the false positives. So what is a false positive? Well, in the popular press, when they talk about mammography, a false positive is when a woman has a screening mammogram, she receives a letter in the mail a few days later or a phone call saying that she needs to come back for additional views. Well, 10% of the patients that we screen will have a callback, so that's considered a false positive. But if you actually look at the definition of a false positive is when you have a medical test that tells you you have a disease when you do not, and mammography does not do that, because most of the time when we say there's no disease there, there is no disease there about 99% of the time. The other harm of screening mammography is overdiagnosis. And then, of course, there's radiation exposure. So let's talk a little bit about false positives. For every 1,000 women screened, 10% will be recalled for additional imaging. About 2% will be recommended for biopsy, and 5 will have cancer. 56 to 60 will be recommended to return for screening in 1 year, and about 25 will be instructed to calm down and come back in about 6 months. I'm going to talk a little bit about my mother institution, Intermountain Healthcare. I know some of you work for Intermountain Healthcare, some of you for the university system, and some of you for other hospitals. I want to say up front that I think Utah does an excellent job in breast cancer screening and with the surgery and the treatment. Although one thing that is not good about our state is our screening compliance rate is one of the lowest in the country. We're either 46, 47, 48, or 49. I don't think we've ever come in at number 50. And that means that usually in this state, about 65% of women have had a screening mammogram who are eligible for it in the last 2 years. Not every year in the last 2 years, so I think we could do better. But in Intermountain Healthcare, we consistently meet national benchmarks for callback rate, cancer detection rate, and acceptable biopsy rates. We have coordinated care with multidisciplinary weekly prospective breast conferences. We have diagnostic care coordination I'll talk about in a minute. And we adhere to strict standards of care. What we like to do in our center and at McKay Hospital, where Mike Webb works and is one of their stellar mammographers, we try to get our patients back in within 48 to 72 hours so that anxiety is reduced. We offer same-day biopsy at many facilities at Intermountain Medical Center. Anybody who has a highly suspicious lesion, because we have 3 radiologists working full-time, 3 ultrasound rooms, and 7 mammography rooms, we will actually do the biopsy that day. And I'll tell you another thing we're doing, we're placing a clip that day, and it's not just a metallic clip, we're placing a marker called the Savvy Scalp marker, which the surgeon can detect at the time of surgery with a probe, so the patient doesn't have to come back and be localized. So the day of wire localization is over. McKay Hospital was very innovative in that they used a radioactive seed before we started using this Savvy Scalp marker, and that allowed the surgeon, and many of you probably did that, to go in, dissect directly down to the tumor without having to follow the course of the wire. So we have made some advances, and I'll talk about that, some of those things in just a few minutes. About 95% of the biopsies recommended from screening are minimally invasive, and I have to tell you, are minimally invasively performed. When I started breast imaging in 1991, 100% of suspicious mammographic findings went for surgical excision. Now a surgical excision is rare because we do the biopsies minimally invasively with either ultrasound guidance or stereotactic guidance. This would not have been possible without the cooperation of our surgical colleagues, because when I started my practice at LDS Hospital, we had several fine surgeons, and I relied upon them to perform the localizations after I had placed the wire. And then when we went to stereotactic biopsy, there really wasn't much pushback. When we went to ultrasound-guided core biopsy, there wasn't much pushback because the surgeons realized that it was the best thing for the patient to do that, and now it's just the standard of care. Talk a little bit about overdiagnosis. Recent reports of overdiagnosis have failed to take into account the increasing incidence of breast cancer. So one of the things that came out in a report by Blyer and Welch that was published about 5 years ago was that there must be overdiagnosis in breast cancer because the numbers of breast cancers reported over the last few years keep going up more than you would expect for the incidence. And they said that that was obviously because of overdiagnosis. What they failed to take into account is that the underlying incidence of breast cancer has been going up by 1 to 1.5% since 1940. And we know this because Connecticut kept very careful data in their tumor registry. And before the era of screening in the 1980s, there was this 1 to 2% underlying increasing incidence of breast cancer. So when they looked from 1985 until when they published their article about 5 to 6 years ago, they said, well, we've got this excess number of cancers, but they failed to take into account this underlying increasing incidence. There's also another important thing about overdiagnosis. There is no way to know which cancers, if left untreated, would be lethal. So how many patients do you know would be willing to just watch their cancers? We don't know. And there is no documentation, imaging documentation, of regression of an invasive breast cancer. Now, I do see breast cancers that will regress without surgery, and those are older patients who opt not to have surgery that are placed on tamoxifen or other aromatase inhibitors. The ACS judged that the evidence for overdiagnosis was really scanty, so they basically said that overdiagnosis was not an issue. However, I have to be honest and say that as a radiologist, we may be overdiagnosing low-grade DCIS, and we may be overtreating that as medical specialists. When I started doing breast imaging, more women underwent radiation therapy for low-grade or intermediate-grade DCIS. A lot of those women are opting not to have radiation therapy, and I think that's a good thing. Fewer women are undergoing chemotherapy now that we have Oncotype DX and we have other tumor markers. So I think that the harms of screening mammography are actually going down. And I think the press is wrong. Let's look at a couple of things that make mammography, screening mammography, better than it was 25 years ago. First of all, the patients who are being diagnosed are not having to undergo 2 surgical procedures to be diagnosed. They're undergoing a minimally invasive biopsy and a surgical procedure. Also, for the vast majority of women who are undergoing biopsy, 70% of them will have a benign diagnosis. So we have really avoided many unnecessary surgeries since the 1990s. Also, our treatment is more sophisticated. As I mentioned, we are radiating fewer women, and we are giving chemotherapy to fewer women with certain tumor types. So screening mammography is not to blame for overdiagnosis or for overtreatment. Radiation, I think it's fairly settled that the impact is negligible, and it's not really considered a harm. What about annual versus biennial screening? Well, if a woman chooses to undergo screening every other year, then the mortality reduction, even in the task force report, was lessened by about 20%. When the ACS looked at it, they said it was probably on the order of 50%. Updated cancer intervention and surveillance modeling network demonstrate a 30% reduction in benefit in annual versus biennial screening. Now, here's something that's very important to note. The incidence of breast cancer increases with age, roughly doubling between the ages of 35 and 40. This is a very busy graph, but I just want to direct your attention to what happens between the ages of 35 and 39, with the incidence from 59.5 to 122.5 breast cancer incidence per 100,000. And you'll notice as you go down the age column that the breast cancer incidence increases until the 80s. So why would you not continue to screen women over 75, especially since women are living longer? If a woman lives to be 80 years old, or if a group of women lives to be 80 years old, about half of them will be alive in 10 years. I think most of them, or many of them, would choose to be treated. Now, if you have an elderly woman who has a lot of comorbidities, I think it's important and ethical to have a discussion on whether or not she should continue screening. And this just shows the years of life lost to breast cancer. If you look at the years of life lost, about 40% of those years occur in women under 50, so it's very important that they be screened. Now, here's some of the latest data that we have, and this was published in Cancer by Laszlo Tabar, who's really the grandfather of mammography. And the incidence of fatal breast cancer measures the increased effectiveness of therapy in women participating in mammography screening. And we will cut to the chase here. And basically, what his study showed is that when women undergo screening, that the incidence of a fatal breast cancer death decreases significantly. And I won't bore you with all the details. But basically, let me get to the, you can see that, let me get to the most important slide here. And I think you may have these slides, but I think the important thing is that those Swedish studies, recent Swedish studies, corroborate what the ACS had described in its report, that we can really decrease the mortality by up to 50%. So, in summary, although treatment is important, that study in Cancer, which you can read in 2018, November, demonstrates that screening mammography cuts the risk of dying from breast cancer by 47%. Although all patients with breast cancer stand to benefit from advances in breast cancer therapy, the current results of that study demonstrate that women who have participated in mammography screening obtain a significantly greater benefit from the therapy available at the time of diagnosis than those who have not participated. So this is what we do at Intermountain Healthcare. The University of Utah is in agreement. I have a close relationship with the radiologist there. And the consensus among our experts is that annual screening mammography should begin at the age of 40 for average risk women, continuing for as long as a woman is healthy. Although after consultation with their primary care providers, some women may choose to transition to biennial screening, they should be informed that by so doing, that they may decrease the screening benefit. So that concludes the portion of my talk about screening guidelines, and I don't know if there's time for questions and answers, but I I want to talk about some of the advances that have happened in breast imaging. Do I have a few more minutes, Mike? Pardon me? Okay. Take 5 minutes, and I want to talk about some of the exciting things that have happened. When I started in 1991 at LDS Hospital, when we would call back a woman for an abnormality on the mammogram, we didn't call her on the telephone. We simply sent a letter, and that was standard of care. And it would often take about a week or two for that woman to come back in. And then if the woman had a suspicious abnormality, we couldn't biopsy it then. We sent her to a surgeon. And the surgeon would consult with her, and the surgeon would do surgery. Then the woman would go to a radiation therapist and an oncologist. And sometimes the process would take months. And we know this because in 1999, we decided to hire a consultant to come in and see what we could do to improve what we were doing in breast care for the patient's benefit. The consultant came in and said, you have wonderful providers here in your system. You've got good radiologists, you've got excellent oncologists, good radiation therapists, your primary care providers are earnest, but your patients are not happy because the process is taking too long and there isn't coordinated care. So our consultant recommended that we do things a bit differently, that we have a weekly multidisciplinary conference, and we started at LDS Hospital with the first tumor-specific weekly multidisciplinary conference that we do at IMC right now. We discuss about 15 cases a week. McKay-D has a weekly tumor conference. They devote at least 30 minutes to their recent breast cancer cases. And these are all working conferences where the clinicians involved in that patient's care are getting together and talking about best treatment. This has changed the way we do things. Well, what do we do about these long callback times? Well, we decided that what we would do is instead of waiting for the patient to call and make a return appointment after she was told she had an abnormal mammogram, we would call her on the phone and try to get her in within 48 to 72 hours. Then, to obviate the need for having her come back on yet another day in another week, whenever she could get off work, we decided to offer same-day biopsies. So that brought the time down. And then, as I alluded to a few minutes ago, there's a new innovation called Savvy Scout. How many of you have heard of the Savvy Scout? We started using Savvy Scout because our surgeons wanted to use it at LDS Hospital. Dr. Teresa Reading piloted it with us. And what the Savvy Scout marker is, it's similar to the seed marker. I will be honest with you, we tried for a couple of years at IMC to get the radioactive seed, but because of obstacles in our system in Salt Lake, we weren't able to do it because we wanted to place it in one hospital and transport the patients to various hospitals. So rather than go with the radioactive seed, we decided to try this Savvy Scout marker. It was so popular with our surgeons that they all adopted it. And so what we would do is we would place the Savvy Scout marker on the day of surgery, and we would do the nuclear medicine injection, the sentinel node injection, at the same time. Of course, the patient had to come back after her biopsy. She'd have to check in about 2 or 3 hours before her surgery to do that, but it was cutting-edge care at the time. So about 8 months ago, we decided that, well, when we have very suspicious lesions, why not just place the Savvy Scout marker at the time of biopsy? So when we do an ultrasound biopsy, instead of placing the regular metallic clip that will have to be localized later, we put in the Savvy Scout marker. The Savvy Scout marker has been approved by the FDA to stay in the breast forever. So at first it could only stay in for a finite amount of time, but now it can stay in forever. So in any lesion that is what we call a BI-RADS 5 or a highly suspicious lesion, we put in the Savvy Scout marker. But then there was the problem of the sentinel node injection. Well, what do? We still have to call the patient back on the day of surgery or before surgery 24 hours to inject the sulfur colloid. Well, because of our good colleagues at McKay-D Hospital who were having their surgeons do it in the OR, we thought, well, you know what? We can train our surgeons to do that. So on January 2nd, we started training our surgeons, and all of our surgeons do their lymphoseek injections right after the patient has gone out. I had to go up and train the surgeons, and so what we did was as soon as the patient goes out, we give her that injection. And for those of you that have been involved in breast care, you know that the most painful part of the process for many women was that sentinel node injection in the radiology department. So what we've done is once we have done the biopsy for highly suspicious lesions, we place that Savvy Scout. She does not come back to breast imaging. That saves quite a bit of money, even though the Savvy Scout marker is more expensive. It would have gone in anyway. She doesn't come back to imaging, so she doesn't get those charges from radiology. Our income goes down a little bit. Patient satisfaction goes up a lot. And since our surgical colleagues have been so quick in adopting doing the sentinel lymph node injection in the OR, that happens there. Our patients are delighted. And this is a standard that is being adopted across the system. I think one of the important points that I want to make in that is that we've had collaboration across the system between Intermountain Medical Center, McKay Hospital, and some of our sister hospitals. And we've had collaboration among specialists. We would not have been able to do any of these things without the cooperation of our surgeons. I've always admired my surgical colleagues. I was lucky enough to train at UCLA with Armand Giuliano. Some of you may know Armand. Not only was he a renowned transplant surgeon, he also did the original work for the sentinel lymph node trials back when the American College of Surgeons did their trials. And at Elias Hospital, we were, I think, the largest accruer of patients west of the Mississippi under Dirk Noyes. How many of you remember Dirk Noyes? So Dirk was instrumental in doing sentinel node injections, and he used to do them all. It's funny how far we've come. Dirk used to do all the injections. He said he was tired of it. So then the radiologists started doing it. Now we're back full circle. The surgeons are doing it again. Anyway, I want to thank you for your attention. And if you have any questions, I would be happy to answer them either now or afterwards. I'm going to stay for a little while. It's the least I can do since I arrived 10 minutes late. Thank you very much. Yes.
Is there still a place if patients be doing breast self-examination monthly and physicians be doing breast examination?
Okay, this is now off the record. I think if women are comfortable examining their own breasts, they should continue to do it monthly as was taught them. I also think as part of any good clinical examination, breasts should be examined by clinicians who are comfortable doing it. Now, if women and physicians are not comfortable doing it, it's even more important that they have annual screening mammography because that may be the only way to detect it. One thing I forgot to say about 3D mammography is that we know with recent studies that 3D mammography actually is better in patients with very dense breast tissue and patients who are at high risk. And about 70% of the mammograms that we're now doing in Intermountain Healthcare are 3D. Mike, what is your experience at McKay? It seems to be getting more and more. And I want to tell you that it's the bane of the radiologist's existence. We used to look at 4 images of the breast, 2 CCs, 2 MLOs, but now with 3D or what we call tomosynthesis, we're seeing 1 millimeter increments. So if you have a 5 centimeter breast, we've got 50 images times 4. So what was 4 is now 200. So our workload has increased significantly, but it's reduced our callbacks because the overlapping artifacts that we used to see are sometimes resolved with 3D, and it is showing areas of architectural distortion, which in the dense breast tissue can sometimes be the only clue that there's an underlying mammographic abnormality. So I think we're doing a much better job with 3D mammography. And, you know, we haven't decreased mortality to 100%. And until we have, I don't think that we can declare victory. One other thing I want to mention, Intermountain Healthcare is involved in a study of patients. You know, one of the things that I would like to have happen is to ultimately be out of a job, to have a test that's better than mammography, a blood test. So Intermountain has a genomics arm based in St. George under the directorship of Lincoln Nadald, and Lincoln and I are collaborating in a project where we have drawn the blood of 650 women. 400 underwent screening and about 250 had breast cancer, and we are looking for circulating RNA fragments which may indicate breast cancer before it can be detected on imaging or or not. We'll see. So we've looked at our breast cancer patients, half of which have had their cancers detected on screening. So we have three groups. We have a screening group that was normal. Their blood tests will be analyzed. They're being analyzed now. We've got a group of breast cancer patients who were detected on screening. We're looking at their blood. And then we've got the group of patients who had palpable abnormalities or other clinical findings, and we're looking and comparing those circulating RNA fragments. That's above my pay grade. What I'm doing is I'm analyzing the images, and we enroll the patients. We got a large grant from a local foundation in Salt Lake to do this study, and we should have preliminary results in about 2 or 3 years, and we are cooperating with Stanford. So Stanford Genomics is helping us out with this project. So I'm working toward my own professional obsolescence. Any other questions?